Good afternoon or evening, depending on where you're joining from. My name is Michael Betel, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risk, causes, and complications of fatty liver disease and help those already diagnosed with MASLD and MASH by advocating for access to approved treatments and care. In June of this year, the American Diabetes Association released guidelines stating that every adult with type 2 diabetes or prediabetes should be screened for fatty liver disease. Today, we will unpack the complex association between diabetes and fatty liver disease and what liver specialists need to consider now and going forward when treating patients with both conditions. To lead that discussion, we are fortunate to have with us one of the most respected endocrinology researchers in the world, Dr. Ken Cusi. Dr. Cusi is a professor of medicine at the Division of Endocrinology and Diabetes and Metabolism at the University of Florida. His expertise is clear, having published more than 250 peer-reviewed manuscripts in the fields of NASH, obesity, and diabetes. He has worked on both the mechanisms causing type 2 diabetes, as well as the interaction between type 2 diabetes and NASH. We have with us the perfect speaker for this important topic. As a note to our viewers, in alignment with the recent nomenclature changes, you may be hearing the term MASH instead of NASH, which stands for metabolic dysfunction-associated steatohepatitis, and MAFLD in place of NAFLD, which is metabolic dysfunction-associated fatty liver disease. Before we begin, I'd like to thank our sponsor, Sonic Insights, makers of Velicur, an ultrasound-based advanced liver assessment tool that conveniently quantifies fibrosis and steatosis in a point-of-care setting with accuracy comparable to MRE and MRI PDFF. As the need for screening increases, the need for accessible, accurate, and affordable tools like Velicur will become greater. There'll be time for questions and answers, so please post your questions in the chat function. I'd now love to turn it over to you, Ken. Take it away.
Well, thank you very much, Michael. With that introduction, I mean, I'm a little bit intimidated, but what are friends for? Hey, we had lunch the other day, so now I guess and I think I invited you, so thank you very much. Well, I want to thank Velicur, because these kind of educational opportunities are very important, and a chance to reach people all over the world. I mean, it's something exciting. There's a lot of change in the field, new recommendations, and new ways to diagnose and to treat NASH, particularly currently for drugs for the treatment of obesity and diabetes. So I'm going to go over a number of important aspects that I think can help you. I understand that it's an audience predominantly of hepatologists and gastroenterologists. Do something to help your patients drift into cirrhosis. So with that, I'm going to move on here, basically trying to give you useful information to use tomorrow in the clinic, what every liver specialist should know, and give you some tips from the endocrine side, because I'm an endocrinologist. So these are my disclosures, largely for drugs that are to become available hopefully one day, and NIH grants where we screen people. And with that, we're going to dive right in. So why? The typical question I get is, why type 2 diabetes? So I'm going to share with you a little bit the latest numbers in terms of epidemiology, and I promise not to bombard you too much with that at this time of the day. We probably all had a long day already. So we're going to make this fun, not as much fun as a happy hour, but more or less. And then who are those at risk of progression? That's what you need to know in the clinic. Number two, there being a number of guidances and guidelines for primary care and endocrinologists, and you all are aware of the updates of the AASLD last November, published in Hepatology not long ago. The ADA in June, I was able to present at the ADA work done by the American Diabetes Association for the past year, which are aligned with ADA, but I want to highlight some aspects, because some of you deal a lot with people with diabetes. And where I really want to focus is down here on management. How are hepatologists going to work with primary care doctors, diabetologists, and the diabetes teams to together do a more effective management of people with NASH or MASH? And then how to use, we are very familiar with using two drugs, GLP-1 receptor agonists and pioglitazone. I'll tell you, the good and bad of both. And in the last 5 slides, just a little bit among the many drugs that are in development. Okay, that's where I live, Gainesville. Mike came to visit me last week, so I appreciate that. I hope, as I promise not to do a liver biopsy or send it to my friends on the first visit. And anyway, you're in perfect health, so I'm happy you don't have that problem. This is where I've seen patients at the VA for almost 25 years. This is our university hospital, has 1,111 beds, easy number to remember. And let's now talk a little bit, try to unpack this complex relationship between type 2 diabetes and NAFLD. This is, I like to say, is like an odd couple that get the worst out of each other. So if you have type 2 diabetes, you're probably going to have more steatohepatitis, be more prone to cirrhosis and to liver cancer. For decades, there have been a number of studies showing why do people with diabetes get a threefold higher rate of adenocarcinomas. And that's the link has been obviously, as you're thinking, NASH and chronic inflammation. But if you have NAFLD, you also make the work harder for us because typically they need more medication, they're more insulin resistant, have more dyslipidemia, more cardiovascular disease. So it's critical, and before I forget, not to stop the statins in people with elevated liver enzymes due to NAFLD, because they are going to most likely die of cardiovascular disease above anything. Now, there are several studies now, and like 2 or 3 studies have been prospective studies trying to identify what is the real prevalence of fatty liver among people who come routinely to visit their endocrinologist or the primary care. And it's 7 out of 10. That's why we don't think anymore recommending ultrasounds, because you have 2 out of 3 chances of being positive. So we have to use better ways to do this, and we'll dive into that. The prevalence of fibrosis is about 20%, but again, liver enzymes, as you know, for a long time, are not very helpful. Unfortunately, I guess that gastroenterologists and hepatologists are still getting elevated liver enzymes as their #1 cause for referral. So that's what we're trying to change with the guidelines. And again, this is with the transient elastography that you're so familiar with. 15% of patients have clinically significant fibrosis, F2 or greater. Again, liver enzymes doing a poor job. Now, you say, well, that's because you're using 40, but if you use 30, it just improves a tad bit. So liver enzymes is not the right approach. Now, there have been enhanced studies by Dr. Serdulo and others with similar results, a beautiful study by Dr. Harrison, the group of Dr. Lumba. The numbers are about the same. Not only that, but that 15 or 12 to 20% rate of advanced fibrosis has been seen all over the world. What we did here with Professor Stefan, an endocrinologist in Germany, we plotted the rate of diabetes, type 2 diabetes, to that of steatosis and steatohepatitis and fibrosis. And as you very well guess, where there's more diabetes in all these regions in Middle East, some countries in South America, United States, you get more steatohepatitis. The question is, why? So let's see if we can unpack that. So if we understand why, you will understand who are those at higher risk of disease progression, okay? So the first question is, how much of this is due to obesity? How much is this due to type 2 diabetes? So if you just now concentrate in this group and those who are overweight with a BMI less than 30, you see that diabetes is the risk factor. Half of people who are overweight with type 2 diabetes have steatosis, and I'll show you later that a significant number have fibrosis, compared to just a few of overweight individuals. Actually, overweight individuals without diabetes have a low rate of fibrosis. Now, if you go into the obesity range, this is enhanced data using USFLI, which is a well-validated test for steatosis. Now, 2/3 of people with diabetes have steatosis, and most of them, once you get to a BMI higher than 35. So diabetes is the risk factor, with obesity interacting to make it even worse. Now, when you look at the rates of fibrosis, again, people with diabetes have a higher rate, and this is by a FIB4 cutoff of greater than 1.67, which tries to capture more people with F2. But if you look at the traditional cutoff of 2.67, again, people with diabetes have a 2 or 3-fold higher rate. Again, it's diabetes together with obesity that tends to be a problem. Now, one question that I get, okay, well, if it's diabetes, it must be hyperglycemia. And hyperglycemia causes a little bit more steatosis here in the same enhanced study with Dr. Barb, who is an associate professor here at the university with me. His office is just next door. You see that it goes up, and this is being consistent. But when we look at fibrosis, fibrosis was not higher. So although steatosis tends to be higher with higher A1Cs, fibrosis doesn't. Now, there was a paper that some of you may have seen in hepatology from Alexopoulos and Dr. Manal al-Ben-Malik saying, oh yeah, A1C, the year preceding the biopsy, does promote more NASH and more fibrosis. And they saw a small increase in the odds ratio with a modest p-value. And again, a little bit also for steatosis and compared to higher A1Cs. But you see that if you look at this more closely, this is plotting the odds ratio over that of the A1C. A higher A1C doesn't translate into worse steatosis on liver biopsies. Ballooning, if you look in the range of diabetes 7 to 9, it's pretty flat. And again, very little interaction. If you look at portal inflammation or neck inflammation, again, not really related. And fibrosis is pretty flat after an A1C of 7. So A1C and glycemic control, at least from this study, is kind of a shaky factor. And with this slide, it's a complicated slide, but if you understand this slide, you almost graduate as an endocrinologist, okay? So let me walk you through this. It's going through the stages of people with NGT, means normal glucose tolerance. This is the healthiest people you have out there. You give them 75 grams of glucose, the glucose remains below 140, typically below 120, and typically these individuals don't have steatosis. Now, if you move into lean individuals with fatty liver, you are going to begin seeing that the glucoses begin to trend upwards. And this is insulin sensitivity. Forget about insulin clearance. This is a confounder. If you look at insulin sensitivity, it begins to now drop, okay? Now, what happens is still, even if you're obese, and obese will add insulin resistance to the equation, more insulin resistance. So somebody who's lean with steatosis probably has insulin resistance. If they're obese, it gets worse, but your glucose levels is just a little bit going up. Why? Because you're cranking out insulin like crazy, so to compensate. Now, for a reason we don't know, this compensation reaches a peak. And if you have a mom, dad, or both with diabetes, there's a defect for which the beta cells begin to collapse. Now your sugars are going up. Now you have type 2 diabetes and hyperglycemia. And as you progress in time and severity of hyperglycemia, you have more and more beta cell failure. But you already maxed out your insulin resistance in the diabetes range. What am I trying to tell you? What is driving steatosis is insulin resistance. The term metabolic dysfunction added now to MASLD and to MASH is really insulin resistance. It's just that we couldn't come up with a good name for insulin resistance, but this is the problem. And when you have type 2 diabetes without insulin resistance, you don't get steatosis or you don't get NASH. But if you have insulin resistance, that is the problem, okay? So we looked at, again, in a recent study with a group from Spain, Dr. Maria Teresa Julian and Dr. Mauricio and Alonso. We looked at the different factors. A1C was really not different in the 3 tertiles if it was less than 6.5 or greater than 7.3. Liver stiffness by transient elastography was not different, nor, but what was really making a difference was atherogenic dyslipidemia. In other words, if you can see the atherogenic dyslipidemia you see in clinic, high triglycerides, low HDL, that is a very good marker of insulin resistance. So it is insulin resistance, the true marker of disease progression. And we just published a paper a few months ago with a lot of friends from primary care. This is probably my paper with more authors, but I had a lot of people to thank to. If you look at people in primary care, there's almost 500 people looking at people with diabetes who had fibrosis, an F2 or greater compared to those without fibrosis. You see that they have higher BMI. Those with fibrosis have higher BMI, higher blood pressure, this atherogenic dyslipidemia with high triglycerides, low HDL, and they tend to have a higher liver enzymes. But more importantly, you could see that their A1C was not different, 7.7 compared to 7.5. But what we did look at is whether the quality of that adipose tissue could play a factor. And we have an index that is similar to the HOMA for insulin resistance. HOMA is glucose times insulin. Here we use free fatty acids that are coming from the adipose tissue times the insulin level. Why do we use that measure? Well, when you are obese, the real metabolic defect is that that tissue stops responding normally to insulin. In other words, what insulin does after a meal is put nutrients into your fat, into your adipose tissue, particularly subcutaneous adipose tissue. As you gain weight, the problem is not that you have more fat, but that it gets sick. So it stops or decreases its response to insulin. So what that means, instead of insulin putting fatty acids into the adipocyte, now it's coming out. As I was telling a patient this morning, this person had cirrhosis. Your obesity is like having a drip of alcohol 24/7 hitting your liver. These fatty acids are accumulating in your hepatocytes, causing toxicity to those hepatocytes, activating inflammatory pathways that lead to fibrosis and cirrhosis. If you want to halt that cirrhosis, we have to do one or two things: lose weight or change the biology of that fat to become healthy again. And that's what pioglitazone does. So we'll tell you more about that in a little bit. So to summarize a little bit where we are, you can be obese. Most people with obese are going to be insulin resistant. They have dysfunctional fat, as I just mentioned. They just don't respond to insulin. And when you have this chronically, this is going to lead to steatosis. But you can have steatosis without features of hypertension, dyslipidemia early on. And that's what we see a lot in people, in young adults in the 20s to early 40s. Somehow, over time, you begin developing hypertension. As I showed you in the prior slide, your fasting glucose begins going up. Your response to a glucose tolerance test, 75 grams of glucose is abnormal. You have higher insulin levels that drive de novo lipogenesis and fat accumulation in the liver, and you develop type 2 diabetes. So this is the picture, the natural history of your patients. And if you want to know who are those who are going to get cirrhosis, it's going to be the people that accumulate more of these features, that have diabetes for longer duration, and that have more severe obesity. Now, let's look at it in a different way now at a more molecular level. We have tried to develop drugs that halt fibrosis, but that's been a very difficult proposition. Most of the drugs, the last one being obeticholic acid, have failed. I think one of the main reasons why the antifibrotics are failing is because we don't know what those pathways are in humans. 99% of what we know comes from mice. And rats behave very differently than humans, at least at the liver level. Now, the other approach is to stop the attack on those fibrogenic pathways. How do you do that? Well, you stop fatty acids from getting to the liver, which are going to be the building blocks for triglyceride synthesis. So a triglyceride is a backbone of 3 carbons of glycerol and 3 fatty acids. So that the liver receives those fatty acids from the adipose tissue and reconverts it into triglycerides that later on accumulate and form some lipid toxic metabolites. The best studied is deacylglycerol, but also ceramides that cause mitochondrial dysfunction and ER stress. When this happens, it sends signals to the Kupffer cells that are going to release a number of cytokines and activate stellate cells, and these now begin laying collagen. Now, all of this is a back and forth. You lose weight, things get better. And if you have gain weight, it gets worse, and many other factors, or develop diabetes. One way the system tries to escape is by increasing the secretion of the LDL that carries with it a lot of triglycerides. And again, high insulin and high glucose promote this entire pathway. So this is a fairly complicated literature, but I would say that pretty much this is where we stand today on the knowledge of the disease. So it comes that if we don't know what the pathways are for fibrosis development, if we do this, what I call a shotgun approach, we reverse the metabolic abnormalities, we reverse the metabolic dysfunction, we overcome the insulin resistance, we are going to see that fibrosis tends to diminish or halt or sometimes reverse itself. Okay, so with that, we addressed a little bit the beginning of diabetes is a key factor in the development of NASH. Number 2, that it seems to be more linked to obesity and how sick your fat is. And 3, that the logic follows that if you either reduce the amount of sick fat by weight loss by any means, or change its biology, like with insulin sensitizer that targets adipose tissue like pioglitazone, things can get better. But before I tell you about management, let me just, in 5 slides, tell you what has been the latest in guidelines for your primary care providers. I know you're a hepatologist, you already are on top of all of this, but share this information with your team because I think it's very valuable. Well, the first thing is that in 2022, and I have to thank a number of friends and Dr. Scott Isaacs, which was the co-chair, Dr. Barb, my colleague here at UF, and also this guideline was co-sponsored by the American Association for the Study of Liver Disease. And I need to especially thank Dr. Rinella, Dr. Yanusi, Dr. Voss, who did help a lot with the PEDS part of this. And we tried to make it very simple, and maybe you should share this with your primary care providers. We now simplified the algorithm to 3 high-risk groups. People with type 2 diabetes and obesity are at the very top. People with prediabetes if they are obese, and then people with obesity who have cardiometabolic risk factors. Other 2 groups are obvious. If they already have steatosis, they belong to one of these 2 groups, or if they have liver enzymes above 30, plasma aminotransferases. After ruling secondary causes and physical exams, you and me have 2 missions. Number 1, stratify for fibrosis. And again, you now, hepatologists, you know, this is your bread and butter. But it is rather new for endocrinologists and the people that you need to send, patients to you. So we want you to get patients before they have cirrhosis, okay? So the second thing is we are learning to do fibrosis risk stratification. I would love hepatologists to begin helping in the management of obesity and diabetes by sending your patient to a nutritionist and starting to prescribe medications, which are very simple. Hepatologists have been managing so many difficult medications like interferon in the past. I mean, managing GLP-1s, it should be fairly simple for you guys. Okay, so AASLD in March came out with the new guidelines presented last year. They want your primary care doctor to do the initial risk stratification with FIB4 plus minus secondary testing, which will be transit elastography, or ELF as the best validated so far. You guys are going to be in charge of the comprehensive management and diagnosis and risk stratification. But again, really important that we do lifestyle intervention. And we already know that just talking them, doing a 5-minute pep talk usually fails. You need to send them to a nutritionist. You need to send them to structured weight management programs or to bariatric surgery. The ADA collaborated with the American Gastroenterological Association in 2021 to create what we call a call to action. This call to action was published in Gastroenterology and 3 diabetes journals: Obesity, which is the Journal of the Obesity Society; Diabetes Care, which is the official journal of ADA; and Metabolism, another prestigious journal. And again, this is what you're doing every day: FIB4 followed by transient elastography. This was adopted last year, actually, by the ADA, and this year we eliminated NAFLD fibrosis score because it overreads. It just gives too many false positives in people with diabetes or obesity, and we added ELF to this workup. Now, I have to say that we, on June 25th, while you guys were all at EASL, I was presenting at the ADA guidelines that we had worked upon to risk stratify people. And again, this is no news for you, is to use the FIB4, particularly to identify people, and not with advanced fibrosis or cirrhosis, but also try to catch those in stage 2, because you know that FIB4, in addition to identifying people at risk for cirrhosis, it also helps identify people at increased cardiovascular risk. The other guidelines recommended, I'm not going to tell you about the screening. In addition, it's pretty much what you're doing, have been doing for the past 20 or 30 years. But I have to say that I think we all as a medical community are failing is to induce lifestyle changes that promote weight loss. Many studies have shown that a structured nutrition program works well. And remember that most of your people with NASH are going to die of a cardiovascular event, 3 out of 4. So that's where you need to help and do a very, very careful job. Now, one recommendation of ADA is that if you have diabetes and you're overweight or obese, you should start using a GLP-1 receptor agonist. Now, if the problem is primarily diabetes and you're overweight or slightly obese, or you should consider either pioglitazone. Pioglitazone costs about $5 to $10 a month, or a GLP-1 that is going to cost $1,000 without insurance, but with insurance becomes much more affordable. So keep this in mind. So the last thing I want to tell you is that the key things is really important is in cirrhosis, you're going to try to use preferentially insulin. And I'm happy to answer more questions, particularly in decompensated cirrhosis. And because of the limits in time, I'm just going to make you aware of this paper we published, Dr. Castera, who's a key opinion leader in Paris in cirrhosis and a good friend of mine. And where we wrote this review, including the different agents, most of them are going to reduce the A1C by about 1% and can be used all the way up to compensated cirrhosis, but you want to avoid them in decompensated cirrhosis and pretty much focus on insulin. Now, remember, people with cirrhosis are going to be particularly prone to hypoglycemia by a number of mechanisms that I described in this review. So you got to be careful, and you probably need to be more aware that in endocrinology, we have a number of devices to monitor glucose. I'll throw a couple of names, Libre 2 or Dexcom, and that is probably something you need to work with your endocrinologist to provide the best care to people with cirrhosis. Finally, the last really quick recommendation from ADA that we promoted in June is help, in this case, targeting diabetologists remember that people with NASH have increased cardiovascular risk, that statins are safe, even in people with compensated cirrhosis. One thing I see, I get primary care doctors that stop the statin because plasma aminotransferases are elevated. You shouldn't do that because statins actually have a number of hepatic beneficial effects at the cellular level. And these individuals have a 3 or higher risk, 3 or more fold increased risk in cardiovascular disease. So please don't stop the statins in your patients. In people with decompensated cirrhosis, probably you should be doing this with caution or stopping it at that stage. Don't forget about metabolic surgery. Only a minority of people that should receive metabolic surgery are getting it at this point. And I would have to say that you should use it with caution once you develop cirrhosis, but you can use it in compensated cirrhosis if it's done in a tertiary center, but not recommended in decompensated cirrhosis because you have increased morbidity and mortality. Okay, so with this, I rushed through some of the background in terms of why diabetes is such a threat to your patients with NASH. Just touch briefly on the recent guidelines so you can tell your primary care doctors and endocrinologists to go and use them as references. Let's get into the management, okay? So first thing, tell your primary care that they have to identify where they are in this lifelong journey from a healthy liver to cirrhosis. What we have done, we have EPIC. What we have done, we have embedded into EPIC the FIB-4. All your primary care doctors have the age and plasma aminotransferases and platelets. They're just not using it, nor your endocrinologist. But we have 2 or 3 clicks and can get the FIB-4. Actually, if you have EPIC, in your notes, if you put .FIB-4, it will come out. Probably as hepatologists, you already know all of this. But for primary care doctors or endocrinologists listening, please do that. The second thing is that if there are endocrinologists in the audience, you should know that we are concentrating the people that have advanced fibrosis or cirrhosis. So this is, again, a paper that we published. We published the main prevalence study. The first slide I showed you about that 70% prevalence of steatosis and 15% of clinically significant fibrosis. We had recruited those people from 3 clinics, the endocrine clinic, internal medicine clinic, family medicine clinic, more or less about 200 in each. But look at this, people with F2 by FibroScan, which again has an area under the curve, which might be lower than in hepatology clinics, but about 0.8. And I'll show you some data about that. You see that it's about 19% have F2 or greater. That's 1 in every 5 person with diabetes. Now, if you go to primary care, other clinics, it's about half of that. So, and again, 1 in 10 have F3 or F4. So talk to your endocrinologist. I know that I have peers that say, well, we don't have this problem. You know, that's a problem of hepatologists. We do have the problem. So tell them, educate them, treat them kindly. You know about this. This is for the non-hepatologists in the audience. FIB-4, if it's in the middle, we do the liver stiffness measurement or ELF, and then we put them in these 3 buckets. If you take 100 people with diabetes who don't know, have never heard the word steatosis, you put them through this algorithm, 50 or 60% will end up in the low risk with a FIB-4 less than 1.3, liver stiffness less than 8, and an ELF less than 7.7. 10% are going to be at this extreme. This is the one that I showed you with F3s and F4. But you can have about 20, 30% in the middle that, of course, you also will have to take care of. So you are going to be helping the endocrinologist, hopefully not in the future receiving people with elevated liver enzymes, but people with elevated FIB-4. And I know you're very worried about getting too many people, but hopefully not. And here you see, this is your AASLD guideline, which we did work as a team to everybody be on the same page. This is where you come to the scene to do additional testing, as you know. And now we're going to touch on why MRE or CT1 or a liver biopsy. Now, again, you might have seen this slide many times, but since I had a broad spectrum of audience, I wanted to share with those that are not as familiar that transient elastography is a great, inexpensive test. But again, it's not as accurate as MR elastography. Of course, it's less costly, but it does help to risk stratify people that we suspect that have F2 or greater. So again, head-to-head comparison showing that obviously MR elastography is better, but it's about $3,000 per MR scan compared to a much lower price. The other thing that we're doing a lot for research is the liver multi-scan. And again, what it does, it takes the liver fat and developing an algorithm based that has been validated with biopsies, comes with a number that tells you about liver inflammation. Again, a value above 825 is probably you have NASH, and above 875, you will have likely F2. So this also has its own CPT codes and is gaining increasing traction, okay? And then we published a paper about that last year, which in people with diabetes showing that they are clearly a problem. Now, here is a case that we published also this year, in which you took a woman, typical patient I see, 55-year-old white woman with uncontrolled diabetes, obesity, elevated AST, and lowish platelets of 193. And again, we did a FIB4. That FIB4 shows that's 2.8. And again, we moved through the FibroScan and to an LSM of 11. And then if we do an MR-PDFF, you see that this person had 10% fat, is iron corrected, T1 mapping is elevated at 908, and this person has F3. So this is basically how you put together the package. Now, what is exciting is that I'm not going to talk about biomarkers, several in development. I want to mention the efforts that Velacur is doing and that are under FDA review, in which the correlation between the elasticity results of Velacur correlate pretty well with 8.6 with MRE and also with MR-PDFF. So this is very exciting news, as it adds a layer of a test that many find very useful and very practical to do. Moreover, I know you're thinking, how does it do compared to the FibroScan? And again, in this head-to-head study, in which, again, the data is under FDA review, you see that the area under the curve of the Velacur is comparable to that, and is not statistically different than the FibroScan. So I think that this is promising development. It's a device that's a little bit cheaper, and again, obviously is in the developing stage of having the large amount of database that FibroScan has over the years, but again, offers an alternative in the diagnosis of patients. And I think we're going to be hearing and seeing many more studies in the near future. Now, with that, let's focus on how do we start these medications. So in the last 10 minutes, I want to cover the drugs that you can use today, because I still have friends in the liver field, many friends, and some say, I'm not going to treat anything until I have an FDA-approved drug. And that's the wrong way to think about this, because the drivers of cirrhosis, you're not going to just pat your patient in the back, say, stop going to McDonald's, see you in a year. There's a lot more you can do. And I have a lot of people on the combination of both drugs, GLP-1s and pioglitazone, that have regressed from early cirrhosis to F2s and stayed flat in that for several years. So let's see. The key thing is that you understand the rationale for treating with anti-obesity and diabetes medications. Weight gain from overnutrition makes your insulin resistance worse, makes your adipocytes work much worse, not respond to insulin, release fatty acids, and that cause lipotoxicity to the liver. And you drop adiponectin levels. Adiponectin is key to keeping fat outside of the hepatocyte because it activates a key enzyme called AMP kinase. If you gain weight, you get diabetes because you worsen insulin resistance and you get cardiovascular disease. So remember, most of your patients are going to die of cardiovascular disease. You can't just leave that in the hands of the primary care. You have to be proactive. Any way that you can do to promote weight loss is going to get this to do better. And also, in this case, pioglitazone, a cheap approach that it works, has been tested over the past 20 years. So again, now let me get you now into more specific information. So in any part of the journey, you can intervene with either anti-obesity therapies, liraglutide or semaglutide, and I'll tell you a little bit more in a little bit, or treat your diabetes with a number of GLP-1s, but liraglutide and semaglutide are the ones that have paired biopsy studies, or pioglitazone, which many studies have done with 30 to 45 milligrams, but we are testing also 15 milligrams and should be the starting dose. We have to intervene before your patients have cirrhosis because cirrhosis is too late. Let's dive into GLP-1. So we wrote this review. I'd like to put this because Dr. Patel Chavez was a fellow who just graduated last year, and with Dr. Kadiyala, one of our associate professors here at UF. Again, many studies had shown that if you look at liver fat, liraglutide or dulaglutide reduced liver fat. But then we had the study by Newsome in 2020. It was reported in 2020 showing a significant effect. Now, I'm sure you're familiar with this. This was impressed in March of 2021. I was honored to be a co-author of this paper. Again, 2/3 of patients had type 2 diabetes, and about 2/3 had F2 or F3. And then the primary outcome was this FDA endpoint of trying to reverse NASH, cause NASH resolution without worsening of fibrosis. So long story short, you might have seen this study 100 times now. That the higher dose, which would be equivalent to the weekly dose of 2.4, which is the dose of Wegovy, which is the anti-obesity formulation, led to about 6 out of 10 improving compared to about 2 out of 10 with placebo. Lots of controversy why fibrosis didn't improve significantly. It improved numerically, but didn't reach statistical significance. But I think that we're missing the point. The most important point is here. If you look in the red boxes at those who worsen in a dose-dependent manner, only 5 out of 100 worsened with semaglutide compared to 20 out of 100. So if you had identify a patient with an F3, you don't need to get them to have a normal liver. You just have to keep them at that point for the next 20 years. And that's what you're going to achieve with GLP-1. Now, notice that the weight loss here was only 12%. Higher doses of semaglutide will probably be more effective and being tested, or newer agents that are promoting even more weight loss. And I'll tell you that in a second. The bad news is in this slide of a recent paper that shows that this was step 1. You saw that you lost about 18% almost of body weight. You stop the medication. If you don't educate your patient on nutrition and lifestyle changes, they regain the weight. And that is true no matter how much weight loss you got. The more weight loss, to some extent, you still keep more weight off, but you regain about half. And this tells you that this is a lifelong therapy with a lot of education. I'll tell you later how to use the GLP-1, but the key thing is to start slowly, train your nurse practitioner, tell them to expect nausea the day or the next day, and titrate it slowly month by month. And if they're hit the wall with a dose that gives them too much GI side effect, you can step back a dose and then wait and then build it back to the next level. Pioglitazone, I published with all these investigators the first proof of concept study. This was followed by a couple of studies, Pivens. We did a 3-year study with similar results of those achieved at 6 months, but sustained over time. We combined it with vitamin E and saw some mixed results, but not really an additive effect as we hoped. And this is a recent study in Asian population. The results are pretty much the same. You start pioglitazone, you see a normalization of liver enzymes, and we repeated the biopsy at 18 months. Frank improvement compared to placebo, as you can see here. And then we converted those on placebo, we added pioglitazone, and they reached pretty much the same result. So 3-year study with very promising results. So people say, oh, it causes weight gain. And I agree that's not what we want, but it improves everything that we talked about before: insulin resistance, sick fat, reduces visceral fat, decreases the chance of diabetes and of cardiovascular disease, in contrast to the opposite with weight gain from excess caloric intake. The other thing is that also pioglitazone reverses all the factors that promote cardiovascular disease. So keep that in mind. And those are the studies for you to look at later. One thing that I typically get a question about, oh, it causes heart failure. That is incorrect. And people who don't have heart failure, it improves left ventricular function. What happens if you have heart failure and you may get edema, it happens in 5 or 8% of the patients, you're going to trigger heart failure. But all the studies in the past 16, 17 years, none have found in a randomized controlled trial to have an increase in heart failure. So very, very important. What I do is to use the lowest dose. I use 15 milligrams, as in studies compared to higher doses of 30, you still get a reduction in A1C with very little weight gain. So this is avoided when I send them to the nutritionist. The alternative is to combine pioglitazone with GLP-1s or SGLT2 inhibitors. So start pioglitazone low, 15 milligrams a day. Combine it if you can with an SGLT2 or talk with your endocrinologist. I avoid it if you have a high BMI or if you already have edema, which is common in people with high BMIs. If you're taking a high dose of insulin, you might gain more weight. And again, be careful if they have a history of osteoporosis. Most studies of bladder cancer have now been negative. And then just follow. If the 15 milligram is well tolerated, just increase it to 30. And nowadays, I just rather use 30 milligrams in most of my patients. This is the last slide I'm going to show you about pioglitazone before we move on to future drugs. If you look at the, if you take people, this is a study that you probably haven't read because it's in the diabetes literature. If you add semaglutide to people on pioglitazone, you have a reduction in the A1C. This is at the low dose of 0.5 milligrams. This is at the higher dose of 1. Again, you have a reduction in weight by adding semaglutide to pioglitazone. And most of your people will achieve A1C that is normal with no weight gain and no hypoglycemia. Whoops. So let me just go to the previous last point, last 3 minutes. What's going on with dual and triple GLP-1 receptor agonists? I have to say there are many, many drugs in the market. The key thing here is to, unfortunately, obeticholic acid and FXRs have not led to what we expected. We're all waiting to see what's going on with FDA and resmetirom. We saw in the New England a recent paper with the FGF21 agonist. The 2 drugs that I can talk from the endocrine perspective are lanifibranor as a PAM-PPAR and dual and triple agonist. So I explained about this, how TCDs work. They have more receptors in adipose tissue than in any other tissue. By healing the fat, you're going to heal the liver. So the key thing is that it seems that lanifibranor by being a PPAR alpha, gamma, and delta, I'm sorry, delta and gamma and alpha, seem to do what these individual PPARs don't do. So fenofibrate doesn't, is a PPAR alpha, doesn't change steatosis. Seladelpar is a PPAR delta, doesn't do that neither, or rosiglitazone, which has no effect on steatohepatitis or fibrosis. But pioglitazone, being a PPAR gamma alpha, saroglitazar, and lanifibranor does. And many of you might have seen this paper where lanifibranor and the native had a significant effect in reducing steatosis and fibrosis. So now they are in a phase 3 study. So that's an important finding. The last three or four slides, I want to talk about tirzepatide. Tirzepatide is a dual agonist. It's a GLP-1 receptor agonist, as semaglutide or dulaglutide or liraglutide, but it has this part of the molecule, which is called a glucose-dependent insulinotropic peptide, or GIP. And where I think it makes a difference is that it's improving the metabolism of fat. Not surprisingly, it's doing really what I said we have to do to reverse NASH, improve fat. These are the results on weight, just to give an idea. And these Surpass trials are all in people with diabetes. You get reductions of 9 to 12%, and even more in people with obesity. And you can see that now the vast majority of people, 80% up to 88% of people, are achieving significant reductions in body weight. The drug is now about to be approved for the treatment of obesity. It's approved for the treatment of type 2 diabetes. What I really wanted to get at is a sub-study that we did with Dr. Gastaldelli and colleagues looking at tirzepatide. How much does it change liver fat? It changes almost by 40 to 50%. And this is very important because, as I showed you before with CT1, this is a very angry, on fire liver. You can see that it's very homogeneous and healthier and smaller in size after 52 weeks of treatment. So very promising result. And the last piece of information is the data that was published last summer in obesity. You can see that you have reductions of beyond 20% with this dual agonist. And now more than 90% of patients are reaching 10% of weight loss. So very, very promising findings, again, with more GI side effects, unfortunately. But we'll have to see how it goes. So with that, I'm going to finish because I want to hear from you. I saw some questions in the chat box. Diabetes drives steatohepatitis through insulin resistance, sick fat and lipotoxicity, and to some extent hyperglycemia. From a practical point, the more cardiometabolic risk factors, the greater is the chance of disease progression. I share with you the guidelines. This is something you've been doing for a long time, but for those who are in multidisciplinary teams, please share with my peer endocrinologists and primary care doctors. And again, I hope the hepatologists start prescribing GLP-1s and pioglitazone and not let your patients drift into cirrhosis untreated. Again, the future of obesity management and diabetes is very bright with new PPARs and new GLP-1 receptor agonists and triple agonists at the ADA. Retatrutide was presented, which is also published in the New England Journal of Medicine, with weight losses of about 27% at the higher dose, and with more than 90% of people having no steatosis at the end of the therapy, 90% of patients. So very exciting. And with that, Michael, I'm going to let you take it home with a few questions.
Ken, as expected, a fabulous presentation. I know we all would have loved for going another hour. Maybe next time we need to book a 2-hour one with that optional second hour. No, really, really great. Thank you for that. I will jump into the questions so that we can get to those before people have to leave. I'll go in order, but you can judge the time that we have. As a hepatologist, what additional risks do I need to understand about my patient with type 2 diabetes? When should they, and I know you believe in that interdisciplinary approach, when should they be referring to an endocrinologist?
Well, number one, I think as I mostly send all my patients with F2, even at least once to their pathologist for secondary diagnosis, for given that they have that expertise, I think you should send them always at least once to see that they don't have renal complications, eye complications, that they have optimized their therapy, that they can switch them from the diabetes medication they're taking to those that work in NASH, because endocrinologists are not that savvy yet, most of them. And particularly, I encourage that all of you as a pathologist always get an A1C in all your patients with fatty liver or NASH, because there's about 20% that are undiagnosed. So I think once, and definitely absolute recommendation if the A1C is not on target, because the endocrinologists have a lot of tips in the same way that you have so many tips for managing NASH. So if the diabetes is uncontrolled, it's an absolute indication. If they're well controlled, still there are so many new drugs that there might be a better fit for their diabetes than the one that they're taking.
Thank you. You did mention that that the specialists, hepatologists, should also take control of their patients in some ways. And one of the questions that came up was for patients that have diabetes and are already on a GLP-1, if they wanted to adjust the dose up for the obesity indication, is that something that they should do? And if they do, what does that do to the diabetes?
Yeah, so number one, the higher the dose, the more weight loss, and we think that's directly proportional to the reduction in A1C and the improvement in NASH. So you should know that the more potent GLP-1s like semaglutide for diabetes is called Ozempic. It goes up to 2 milligrams now, and the same semaglutide at a higher dose of 2.4 up to 2.4 is called Wegovy for the management of obesity. There are only two formulations that are just for people with obesity without diabetes. One is liraglutide, and it's called Saxenda, and the other is what I told you, Wegovy. So you should know that the earlier GLP-1s cause less weight loss, like exenatide, dulaglutide, liraglutide, than the newer ones. So try to put them on the one that, and again, at the higher doses. So I don't want to bury you in information. Unfortunately, the secret is I will only be able to prescribe what your insurance allows, but fight the insurance, okay? You don't have to do it. Get your pharmacist, get your support staff to fight this, because this is really, really key because in addition, most of your people with NASH are going to die of cardiovascular disease, and these medications reduce cardiovascular disease. We have one more minute for the last two questions. So
which one you want to take?
well, should I adjust the FIB-4 cutoff for patients with
Sure.
diabetes? The answer is no. So the cutoff is the same. So it's a great question, though, because there's a lot of caveats with FIB-4. So FIB-4 below age 35 has not been well validated and can give you a falsely low number because the age is low. Same as the other extreme, people say above 65. I play with a little calculator. Every 10 years, it goes up by 0.3. So if it's 1.9 and you're 65, it will be 2.2 if you're 75. The bottom line, the FIB-4 is good to rule out disease. So, however, we chose a FIB-4 in all these guidelines because it was free, cheap, can be done in the United States, in Africa, all over the world with little expense. But again, it's really designed to identify F3s and F4s. Well, we are going to miss some F2s. We knew that because we know that if they captured every single patient, my dear pathologists would be very angry with us because they couldn't take care of them. But we want to start with the F3s, F4s. So the take-home message, please train your nurse practitioner and training your patient using or your pharmacist to train your patient with GLP-1. Don't be afraid of pioglitazone. 15 milligrams, pretty safe, doesn't promote weight gain, and you titrate up to 30. Think that don't leave your patient just walking around without the potential for pharmacological treatment, and consider early diagnosis with FIB4, elastography. We're going to be looking at the new techniques like the Velacore imaging technique. Michael?
Okay, well, let's wrap it up. I want to thank you, Dr. Cusi, for your excellent presentation on this really important liver health issue. And of course, everyone who was able to attend tonight. There'll be a recording of this webinar available in a day or two on the Sonic Insights website. You'll also be receiving a very short survey. It would be great if you could take a minute to fill that out. It would help ensure that we're going to provide valuable education for future events as well. Thank you all again for joining us, and we look forward to seeing you again soon. Thank you.